Good morning, everyone. This is a case of a 19-year-old boy who was student and part-time waiter. He complained of on and off headache and focal seizures involving upper limb and lower limbs with secondary generalization and loss of consciousness. He was put on tablet Eptoin. Despite of that, he had similar episodes of seizures followed by upper limb weakness, which gradually improved. On past history, he had no fever, vomiting, cough, or weight loss. He underwent MRI. So, in the recent MRI, revealed a well-defined, intensely enhancing lesion in the left precentral frontal cortex, which measured 2.5 into 1.6 into 2.1 centimeters. The MRI, which was done almost an year ago, this lesion measured 1.2 into 0.8 into 1.6 centimeters. We have seen it has almost doubled. The lesion was mildly hypointense on T2 and flare sequence and hypointense on T1 weighted images with subtle blooming on GRE sequence. A cystic area measuring about 1.2 into 0.7 into 0.7 centimeters was noted in the anterior aspect of this lesion. Moderate to severe perifocal edema with mass effect in form of effacement of adjacent sulcus spaces were noted. Before the surgery, he underwent other investigations. The triple virus status was negative. His X-ray was normal. Now, in intraoperative findings, this boy underwent left parietal craniotomy and excision of the left posterior frontal lesion under awake anesthesia. Uh, my neurosurgery friends can read this and they're already well versed with this, so I'll skip this part here. So what we received in lab were multiple irregular gray yellowish soft tissue pieces, which aggregated to 2.5 into 2 into 1.3 centimeters. And on histopathology, uh, we found the cerebral parenchyma with effaced architecture, and there were the larval forms of these cystode, this spirometra you can see, and dense diffuse infiltration by polymorphonuclear cells, lymphocytes, plasma cells, and eosinophils. And there were these ill-formed granulomas, which were composed of epithelioid cells and multinucleated giant cells. So we gave a diagnosis of cerebral sparganosis. All the parasites affecting humans may involve CNS. We all know that cysticercosis is the most common CNS infection by the parasites, and the less frequent ones are toxoplasmosis, echinococosis, and schistosomiasis. Etiopathogenesis of human sparganosis. Now, this is a very rare, but because of increasing emerging foodborne zoonosis is caused by the larval form of spirometra, and the most common one is S. mancinoides. And this is most common in the Asian countries like Japan, China. The humans are infected uh, by drinking of untreated contaminated water containing the spirometra, the plerocercoid larvae. Plerocercoid is the infective stage, and due to consumption of raw or undercooked food, frog or snake meat or even chicken, and using of raw flesh on open wounds such as traditional poultices. This is the life cycle. The infected the dog and the cat shed unembryonated eggs in their feces, which get embryonated in the water. These are then taken up by the crustaceans. Now, these form the first intermediate host, which are in turn eaten up by the fish, frog. Um, So the humans who consume fish, frog are most likely to be infected through this, or even those who consume contaminated water may acquire this infection. The most common sites involved in the humans are subcutaneous tissue and the muscles. However, it may occur in the abdominal cavity, pleura, genitourinary system, eye, brain, and the spinal canal. The cerebral sparagnosis is relatively rare but represents the most severe type, and it is characterized by symptoms such as seizures, headache, hemiparesis, and sensory disturbances. Imaging MRI will show the most characteristic finding is the tunnel sign on post-contrast images, and the common finding is the bead shape enhancement and wandering sign in the MRI. Now, this wandering sign is because of the migration of the larva. MRI is superior to CT in demonstrating the extent and the number of lesions. Other investigations which can be done to confirm is antisparagnum IgG antibody in the peripheral blood or CSF by ELISA and molecular diagnostic technique, that is PCR. Management of cerebral sparagnosis includes surgical removal of the worm as well as post-operative administration of antiparasitic drugs such as praziquantel or albendazole. Prognosis: cerebral sparagnosis cases can be cured with praziquantel medication alone and has good prognosis after treatment. Thank you very much.